GE. It is therefore suitable for general viewing.
Good evening. Many thanks for watching KTN. Welcome to this edition of Health and Wellness. We keep saying that your health is your wealth. Today, we're here to talk about IVF, in vitro fertilization. And to have this discussion with us is Dr. Jane Wangui Shira. And we're here to talk about that because when you talk about IVF, Daktari, many ask the question, hini nini, what is IVF?
Okay, good question. IVF is abbreviated from in vitro fertilization, which is one of the types of assisted reproductive technology. So most people take IVF to be all that can be done if you're doing something artificial, but it is just one of the types of ART. So that is what I've said is assisted reproductive technology. And it is where eggs are gotten from the female partner, sperm from the male partner, and fertilized outside the woman's body, and then returned to the uterus. So that is in vitro fertilization. In vitro is when something is done artificially in an artificial setup, as opposed to in vivo.
Yeah. So then one asks the question, who is the perfect candidate for IVF treatment? Is everyone a good candidate, or do we have parameters within the medical field, or basically for those who want to have children, who are the perfect candidates for IVF?
You know, in my learning, I've known that there's absolute words always mean that something is not right. There's no perfect. Just like in everything else in life, there's no perfect. But there are people who can try, who can use it as a means of achieving a pregnancy. And depends, okay? It's not for everyone, and depends on what is the wish of the couple. I cannot prescribe IVF for a couple, but I can discuss it as one of the options. But there are some people for whom this might really be the best option of achieving a pregnancy. These are people who have some conditions. You see, like there are some people who have tubal blockage, okay? With tubal blockage in a female partner. So tubal blockage, I mean the fallopian tubes. You know, sometimes we assume that people know what we're talking about.
What you mean, yeah.
The fallopian tubes are blocked. If that happens, then it means the egg cannot go back to the uterus, and also cannot get fertilized, and the embryo getting back to the uterus. And it also means that the sperm cannot swim to where the egg is found. The fallopian tubes are actually the body's laboratory for making the embryo. So if that is blocked, then for sure we need another artificial means of achieving a pregnancy. But one will ask, why not surgery? So there are some people who can benefit from surgery. There are some tubal blockages that are not amenable to surgery or will not improve with surgery. So such candidates would then benefit from in vitro fertilization. There are others who have the male partner having a very low sperm count, or sperm that cannot swim but is viable. So imagine, usually we say that sperm needs to swim almost like a whole marathon to be able to fertilize. So if that sperm cannot work, then they would need to do in vitro fertilization, but I would want to correct ICSI, because that's where I was going with this ART, because IVF is another sort of fertilization called ICSI, where the sperm is injected, because in vitro fertilization, you're putting the sperm and the egg together. But there's some sperm that cannot fertilize, and so they need to be injected in, and it's called ICSI. So such candidates are good, patients are good for, or couples are good. It's good to have in vitro fertilization. Others are those who need genetic tests. I don't know whether you heard of people who might require genetic tests, because there are many genetic conditions that if people had a choice, or if it's available, it would be better to achieve a baby who you can choose And however, without the moral question is still there, choose and be able to get a pregnancy of a baby who is not affected, because some conditions are not even compatible with life. So these couples, or this woman is conceiving but not able to achieve a baby, even after a pregnancy. And then they would choose the kind of, so we call that pre-genetic testing. Another big moral quagmire is when people need to do third-party reproduction. They're using donor eggs, or they're doing surrogacy, okay, gestational carriers. Then definitely they would need to do IVF, okay? So there are many others are conditions where one big condition we call unexplained infertility. We don't know what is happening. People are just not getting pregnant year after year and after year. And who are these people we call, in fact, who are having infertility? Because some people come after 2 months of trying and say, Doc, I would want to do something, I'm not getting pregnant. Usually, if you're less than 35 years, would say maybe you have been trying for a year without achieving a pregnancy. Then you're said to be suffering infertility. Okay.
Doc, for a very long time, especially in a society where we live in, the African society, what has to do with fertility has been pretty much left for it's a woman problem. You know, it is very difficult to find, maybe that is changing today, but it's very difficult to find men who are taking responsibility and saying, perhaps maybe I'm the problem. Perhaps maybe my sperms can't swim and I need a doctor to help it swim or to help it do the job, right? But as well as just the entire fertilization conversation, like we've just established, a couple must go together for them to go this journey all through. Are we seeing the tides change where more men as well are embracing alternative ways of reproduction?
Good question, Dennis. I think you people, the information age has made a marked difference in this part of the problem. If about 7 years ago, 10 years ago, if you asked me, I would say it's a real challenge to get men on board, to get tested and to agree that perhaps they could be contributing to this problem. But it still does exist. Because I've seen couples where definitely they know, even before they got married, they had a conversation between themselves and they knew that the male has a challenge with fertility. But they, of course, because to protect themselves, and I believe it is someone's personal business, you don't have to tell the whole world. They, of course, don't inform the family. But this family will hound this woman, why aren't you giving us a child? Knowing very well that it's the husband. So the biggest problem sometimes is us, the older generation, but the younger men are embracing this. There are many men who walk in even before they ever get married and say, I want to get tested. I've heard that that my men can also contribute. And before I start bothering my wife, let me get tested. So it's changing, but there's still challenges. Sometimes depending on the age, depending on the socialization, and sometimes just personal beliefs that actually I have such big stamina, I can't be infertile. So, but it's easier. So when they come in, of course, that's why we encourage that. If a couple is trying to conceive, it's better they come together. We are able to walk them there to allow for testing. And testing is painless for men.
So, Doc, here is a question where we have been trying for a very long time. Clearly, we've not been successful. I've gone to my OBGYN, we've gone through the test, and there is a problem that needs to be addressed. Take us through the entire process of IVF, starting from the first consultation to when we are seeing now the embryo transfer. How does that go about, and how then would the conversation start with an OBGYN that would lead towards deciding that IVF then is the best solution?
Okay, that's a good question, because people wonder, they think, I need to have decided. First, we don't even have to have decided that we need to have to do IVF, because sometimes people come for IVF based on what they've been cancelled on or what they've read, and we have to agree to redo and check and see, could a simpler treatment be the solution? So luckily, we have a lot of very well-trained professionals all the way from the lower level hospitals, clinics, dispensaries, and the diagnosis is made. So in most cases, people will have an idea that this could be the challenge. So is it the female partner having a challenge? And even with the female partner, is it one challenge or several problems? Is it the male partner? Is it both? Is it unknown? And from the first consultation is to make the diagnosis. So, do you actually have infertility or not? Have you tried enough? Are there simpler things we can do? Do we need to optimize your natural fertility? Because remember, IVF, and I'm sure it is out there, is not a perfect solution. Not everyone conceives with IVF. It is not 100%. It is not for everyone. So have we optimized your natural fertility so that even if you ever get to IVF, you would conceive? Because we can only work with the gametes or what we have. Do the diagnosis, okay? So are you an ideal weight? Are you having lifestyle challenges that could be contributing to this fertility? Are you eating right? Are your tubes blocked? Is your sperm count okay? Could it be improved? Could your egg quality be improved? Is it absolutely hopeless? Because, okay, not hopeless in terms of, there's some people for whom maybe that party reproduction would be an option because maybe they are not producing eggs, so they would need donor eggs. They are not producing sperm. They would need donor sperm. Is there a uterus that can be used? There's some congenital conditions where we don't have a uterus, okay? I'm sure you have heard of it with a very long name, Rokitansky-Kuster-Hauser syndrome. So they are ovaries but no uterus. Could it be that surgery has been done and now the uterus is so scarred that it's not possible to carry the pregnancy? Okay? And that's why these days we don't have the term barren anymore. There's very few cases where you cannot be able to achieve a pregnancy. You might have to use extra help, what we call the third party, donor eggs, donor sperm, donor embryos, or surrogacy, or optimize your own. And of course, adoption still remains an option. It's not everyone who wishes or can do assisted reproductive technology, and some could go the adoptive way. You could either adopt an embryo or adopt a baby who will benefit from having loving parents. So after you make the diagnosis, then the main place where the main partner who undergoes the treatment is a female partner, even if it might be the male partner who might have low sperm count, because getting the eggs, the first part is getting the eggs out of the body, doing the oocyte pickup. And to do that, we decide what kind of responder is the woman. Is she a poor responder? Because some people have very few eggs. Is she a normal responder? Or is she a hyper responder? Another possible problem in the stimulation, in getting the eggs. And then we give injections. So we'll do the scan, make sure there are no challenges. She didn't have a cyst that could interfere, that is producing hormones at that time. And then we could either treat or defer the treatment to another cycle. Determine what kind of cycle we are doing. There are different types of cycles that are done, and we don't have to get into them. They're very quite technical. So some people will do a longer cycle, some will do a shorter cycle, and then start off the medication. In IVF, the common type of stimulation, and it's not everyone, some places in the world people don't use a natural cycle, but majority of cycles in the world are done using injections, hormonal injections, okay? What we call gonadotropins. So usually they're daily injections. So the clinic could offer daily injections, or the partner herself, or the female partner could inject herself, or her partner injects her, or even a nearby clinic. So every day for usually from around 9 days to about 12 days. Sometimes for some people who have very long cycles can go to about 14 days. And then scans are done in between to just make sure that the eggs are growing okay, doses adjusted, drugs changed. And then we get to the place where we feel that the eggs are mature, they have reached a critical size. We are not able to see the eggs on scan. What we see is a follicle, like the house that holds the egg. And when it is mature, because there's usually maturity of that and it indicates that there's maturity of the egg inside the follicle. We give what we call a final maturation trigger, and then we do the egg pickup. That is 4 to 36 hours later. So the egg pickup has many names: oocyte retrieval, OPU, which is oocyte pickup, or let's just call it removing the eggs. Okay. So the water around the egg is aspirated. It's not surgical. It's just an ultrasound and a very long fine needle. It can be done when the patient is asleep, not asleep. I've been to centers in the West where they actually just numb the cervix. So the client is talking and the fluid pulled out, or we could sedate, and so that they just will give good pain control. And most of the centers in Kenya will give the sedation. The fluid is pulled out and given to a biologist called an embryologist. So the embryologist is a specially trained biologist who is able to handle gametes. So the gametes here are the eggs and the sperm and the resulting embryo. So she will go and get out the eggs from the fluid, grade them, rest them, and then decide on whether to put sperm around them, which is what we call in vitro fertilization, so that fertilization occurs naturally, so that this, for most good sperm or the best sperm will somehow find the egg and fertilize naturally, like would occur in the fallopian tubes. Or if there's a challenge, or sometimes just pure choice, he or she could inject the sperm inside the egg, which is called ICSI. Intracytoplasmic. Cytoplasm is that fluid inside the egg, sperm injection. Then after that, in about 18 to 24 hours, we know whether the egg has fertilized. And then from there on, we go through the stages. So they will start dividing into small cells, which we call blastomeres, small cells inside the big shell that was holding the egg. And then finally, we are going to have what we call embryos, okay, which can be at different stages. So either on day 3 or day 5, but most people will aim for day 5, embryo transfer is done. Now, this is a painless, just putting back the embryo in a well-prepared lining. So the lining could have been prepared by that cycle, because as the egg grows, it also gives hormones that help the uterine lining get prepared, like would happen naturally. Remember, we have said even in the body, the lab is usually separate. Yes. It's usually in the fallopian tube. So the body is busy preparing this lining, ready to receive this embryo naturally. But now in IVF, we do the same. We prepare this lining either artificially by giving hormones, or if it is in a fresh cycle, the eggs, as they were growing, this house that we call the follicle, we're producing estrogen followed by progesterone to prepare the lining. And then on that day, we come a very short procedure with a special catheter called an embryo transfer catheter. We put the embryos back into the lining. We do what we call luteal support, give some hormones, and in 2 weeks, there's a famous 2-week check.
2-week check.
It's one of the biggest exams for both the doctor and the couple. Waiting to see whether after all this money spent, all these emotions, all this hope, whether we are actually pregnant or not. Yeah, so we do a beta ECG test.
So then typically the period then that IVF takes is 2 weeks? Or is it more than that?
No, remember, the first stimulation could take almost up to 2 weeks. We said typically it's about 12 days. Then we do a pickup. 36 hours later, that is almost 1.5 days. So that's about 14 days. So the first part of stimulation is about 14 days. Like I'm sure most people think that all women ovulate on the 14th day. Many of them will ovulate on the 14th day, but it's not everyone. But here we are taking also either 14 days or 12 days, just like would happen in a natural cycle. It really mimics the natural cycle. Then we get the eggs out. They stay in the lab for 5 days.
5 days.
Then we transfer on the 6th day. So that is typically around day 21. It's about 3 days. Then another 2 weeks of waiting to see whether we're actually pregnant or not. Usually about 12 to 14 days of waiting to see whether you're pregnant or not.
You see, when you talk about what technology can do and what improvement in the health sector can do to everybody pretty much, especially those trying to get pregnant, especially in the reproductive sector of the health systems that we have in the country and the world, a lot can be done. The only question is, are we aware of this? And if that's not the case, how do we improve on that? Let's take a short commercial break. We'll be back with much more right here on Health and Wellness. Thank you for watching KTN. Welcome back. This is Health and Wellness. We continue the conversation around reproduction and some of the options that do exist on set. With me is Dr. Jane Mashira. Dr. As we went on the break, we went through the entire cycle, pretty much the entire process that it takes. But one asked the question then, there are couples who, most of the time you find a woman would have their own OBGYN before getting into a marriage or something. But even while at that, you find that there are many who only seek the services of an OBGYN when all else has failed. How critical, how important then is it for all couples, for everybody to start this journey with an OBGYN way earlier so that we're able to deal with these problems before they become something that is now difficult and needs more processes or needs more time?
Great question. Because there are many things that would pick, well, this young lady is not married while she's still in a younger age group. Like, could she be having a hormonal condition that would benefit from long-term treatment before you ever get to be married? I've had young ladies who, when they come to try and conceive, is when they discover that they got premature ovarian failure. And you know it's a process. There are some people whose ovaries, but it's very rare. I wouldn't want to scare anyone. Reproduction stops, or ability to ovulate stops much earlier. So what's the benefit of knowing that there could be a problem is that perhaps they could do egg freezing. That's another reason why people do IVF, because IVF is just an extra step after collecting the eggs. So for some people, if we notice they have a condition where they're likely to stop ovulating early on, we can collect the eggs and freeze them even before, what we call fertility preservation measures. So that's an example of a good reason why someone could seek help earlier. Others could have things like polycystic ovarian syndrome, which is now being called PMOS. Others could have things like endometriosis, which benefits by almost stopping the progression of the disease. If you catch the disease early, then there are measures that can be done, not only surgical, but medications that can stop it from moving from mild disease to worse disease. Others are common things like fibroids that are very common in Africans. So such would benefit from at least having interventions early. And the biggest one, Dennis, infections. Properly educating, early diagnosis and treatment of infections that could lead to fertility problems. And you're not saying that all fertility problems are because of infections, but there are some fertility problems that could be caused by long-term untreated infections in the genital system. So, and also for the couple, almost everything I've said affects, we are talking as if fertility is mainly. So where do the men go when for checkups? Are there male gynecologists? Well,
it's the question. I've always been asking myself that question. Are there?
No, they're called urologists. They are able to investigate the male reproductive system. And there's a big role of your general practitioner for both women and men. Not only general practitioner, even the dispensary, the nurses are very well trained on reproductive health. If there's one good thing is how well trained they are on reproductive health for both men and women. So there's no excuse. From the very rural setup, everyone should be able to get a checkup. And of course, we would want to prevent cancers, especially for women, cancer of the cervix, cancer of the breast, screening, even men. Prostatic cancer is becoming big, and people need to be worked up for prevention of cancer from early on.
Yeah.
Okay.
Yeah. Doc, so let's look at the world where we are today. So there are those women who say, at the moment, maybe stuck in total. You know, it's a couple, they've decided at the moment we don't want kids. But age is equally a factor when it comes to reproduction and having children, you know. So then there are those who would decide we will try it when we are ready. So there's an age factor. In that setting, would you reckon that then it is perhaps before making that decision, sit down with an OBGYN who would then advise you on some of the solutions if you're planning to have children later? So that would be whether you want to freeze your eggs. That would be a conversation that would take then also for the man to go to a urologist to have themselves checked so that they can also freeze their sperms for later days to come. Are these conversations that we're seeing, especially in a world where many are making choices for later, are these conversations being held today? Or are we waiting until when age has passed, it is now difficult that then we're seeing an OBGYN?
Yeah, that's a good point you're bringing up. Reproductive autonomy is big and a right that we are now realizing when you start asking people like this fussy auntie, when are you getting children? You know, because I have a role, especially as a reproductive endocrinologist provider, to ask any lady coming, and when are you thinking you want to have children? It is not to infringe on their right, it's so that I can guide them properly in case they do want to have children in the future. And of course, I respect the autonomy of not having children. There's a whole child-free society, and we really respect that everyone should get a child when they want and if they want. And there are many couples choosing not to have children. And so these conversations, we are learning to bring them up. And most health providers, gynecologists and other reproductive health providers will find out whether people are interested, and especially as time comes. We start to ask these questions around the 30s, because we know that there's really a biological clock for women. Not to scare anyone, and this clock is not absolute. I've seen some females where really the decline in reproductive potential is very early. Others, even in the 40s, they are still able to produce, they're still able to be productive. But because we are following the mean, then we will alert people that perhaps you could think of this, and is it something you'd want to get into, even for males. And they could go to the urologist, or they could still go to the gynecologist, especially if they know one, because, or even any fertility clinic, because sperm freezing is mainly done in the reproductive or the fertility centers. That's where there are programs for sperm freezing, egg freezing, and embryo freezing. And whichever provider will be able to refer adequately on where this can be done. So we're having those conversations, and it's good. I like that you have brought it up. It means that people are becoming more aware of it. Yeah.
So, Doc, there are myths that do exist with IVF. You know, if you take IVF, perhaps that baby will not be as healthy as a baby that is born out of in natural ways. Is that a myth? Is that something to be debunked? Is there facts to that? And also, when it comes to IVF, can I decide that I want to have twins or triplets because of the process? Are these also conversations that do exist?
Yes. That's a big reason. In fact, the last one you've talked about is a reason maybe many people come to reproductive clinics because they're thinking, I just want to get done with this. I want triplets once, or I want, most commonly twins. I want to get twins, multiples, and get done with this. So those are conversations that bring people, and of course we advise them adequately. Is it a good reason to do IVF? No. And maybe we'll talk about that, because when people talk about success, in most cases, depending on the age group, we tend to transfer in this part of the world. In the West, the standard, and it's quickly catching on, is transfer of a single embryo to get a single pregnancy, because multiple pregnancies have problems. Actually, they are high-risk pregnancies, and I'm sure we've seen that. But in this part of the world and in the other parts of the world that are developing, people want to maximize on the potential of achieving a pregnancy in that transfer. So we tend to do multiple embryo transfers. And even when we transfer 3, you could get triplets, you could get 2, you could get 1, you could get 0. So it's not a guarantee that if you do IVF, you're going to get multiples. Even other drugs that are used for boosting, for ovulation induction could also lead to higher chances of multiples. Is it a good reason to go about it that way? Maybe. It's a personal decision and your health provider. But the main question you asked, are IVF babies normal? Yeah, so it's a myth that they're not normal. There was, IVF is not old science. If you think about anyone born, 1978 is how many years ago? That is about 48.
That's 48, yeah.
48 is a technology that has only been in the world for 48. Okay, of course, earlier trials were done, but the first baby was born in 1978. So it is something, well, at least documented, you know. Australia, everyone knows, and the Americas, and now Europe. That was in Britain. That was the first documented baby born in 1978. So there have been many discoveries, many tests, many unbanked myths. So it was thought that there was a higher chance, and of course, it's a slightly higher chance of what we call epigenetic phenomenon and changes. And but it's not as common as people think it is, because some providers will see one in a long time, but most babies are absolutely normal. They have the right of being born and of being recognized as a child as any other child born naturally. Because remember, this is only the fertilization that takes place outside the body, but every other growth is within the woman's body. So I have not seen that number, and I've seen quite a number of IVF babies being born with problems. So it's a very slight increase. And there are lots of changes and lots of checks to make sure that such epigenetic things that could cause changes are on a down low.
Yeah. Doc, IVF, as well as any other procedure, is not 100% guaranteed. There's a chance of failure. And we also equally know that it's highly financially heavy burden for couples that are going through the process. So in the event that one has gone through the procedure and they've not been successful, how do you have that conversation with them? And in the event that they want to try again, what period? Is there a waiting period, or is it just tap and go?
Okay, yeah, that's one of the biggest challenges with IVF or ART in general. It is very highly financially, it's a big financial investment for the couple, emotional investment. You take away almost 3 weeks of your life thinking about this, and another 2 weeks of praying and thinking about it every day. So it's a big burden. And unfortunately, the success rates are not as high as you'd want. And it's not the bigger, it doesn't matter how much you invest in it. It doesn't, it's not like any other business or any other input. It doesn't mean that the results will generally will guarantee you success. So these are conversations we have. And sometimes I sound like a very negative person by starting off with saying it is not guaranteed. Because when you start off by telling people it's not a guaranteed treatment, and we have to optimize so that we improve your success rates, then people start to work around it. And so these are conversations. So definitely after failure, so for most people, even if you give them a rate, you tell them success is these percentages, and it's not one success rate. Of course, centers have different success rates, but what determines the success rate most is the kind of gametes, the kind of condition that the patient is in, or the clients are in. So even if you give them a rate, sometimes they always think on the positive number. Or for me, I'm going to be successful. So later on, you have to cancel them. How fast can you try? Of course, sometimes we would want to give time. Especially stress is a big factor in failure. So people need to recover emotionally, and they could try as soon as possible, because for some, it is in the trying that they are able to keep their positivity. So there's no absolute number of months or time that you can, on when you can try, but you need to recover, both emotionally, financially, especially financially, and also physically. The body needs to get down, because we give very high levels of hormones to get that result.
Doc, I want to bring in something that cause a lot of tension in reproductive circles, and this is where then surrogacy becomes part of the conversation, where an OBGYN has advised that based off what you have, you froze your eggs fine, your husband or your partner has gone through that process, and we are viable, we are able to produce an embryo that is viable, but unfortunately you as the woman, you are unable to carry that pregnancy to term due to challenges that do exist. So then the conversation comes in of a surrogate that would help carry the pregnancy to term. How do you start that conversation, and how easy, how difficult is it for a couple to accept that?
Okay, that's one of the hardest conversations to have. And there are as many patients with different beliefs. There are as many providers with different beliefs. And for all, there's a bit of a morality question. For some, it's extreme. There's some who can do it but are left having questions. For some, it doesn't bother them. Maybe they think just about what will society think. But that's why it's being also very highly regulated. It's one of the biggest medical legal hurdle in the fertility world. So it's a difficult conversation. Who is the initiator of this conversation? Sometimes it may not necessarily be the medical provider. It could be the family, it could be the couple. And then sometimes you have to advise them, is it a good thing to have? Because there's some people who just get tired of doing this and they would want now to use a gestational carrier. And sometimes you have to advise them that maybe you could take a break and try this again, or is this the only solution? So there's no easy way of going about this conversation. Remember, even with the new ART bill that is yet to pass as an act, it's a big question. It's one of the biggest things that is keeping it, the debate going on. There are some religions that would not allow for this. There are some couples who would not even think about it.
Culture.
So, culture. It's really African culture. Who is a parent? So it's a big question, and with a clear direction. Yeah. But for some people, it's the only way to achieve a pregnancy.
Yeah. If you look at a little bit of politics, where now we find ourselves as countries that are doing well are countries that have a huge population. So therefore, then reproductive conversations then become part and parcel of conversations that should be held at a policy level. And here then would come to accessibility, affordability, and also regulation of the same. Where would you place Kenya when it comes to having conversation from that macro level in terms of reproductive technologies and also ART that is now coming up? Where would you place Kenya in terms of getting it right or room for improvement?
Definitely we are doing well.
Yeah.
And sometimes I look at Kenya as having two worlds in one.
Yeah.
We have a super first world population and a super developing population in the same country. And it's unfortunate. And this is, of course, sometimes because of lack of equity, health equity, financial equity. So there are some people who are able to get anything they want. There are some for who they need protection. They need government protection in terms of healthcare. They need to be given the healthcare they need. And that there comes in the problem. There are some people who are able to try to have 10 cycles in this unregulated, because as it's regulated by the board, but there's no bill currently super regulating the provision of ART. But I believe the act will be being passed soon. And that will then give lots of direction. Because even as a health provider, sometimes I'm asked to do many things, and sometimes I wonder, of course, it's a morality question, and I'm wondering, am I acting within what is right? So getting guidance is important for both the client, for everyone involved, and even for the provider. And we are getting there. We are losing because of information and all this, we are getting to where we're able to be regulated. But the other thing that is being, of course, being talked about in that bill is availability of fertility treatments for all.
Yes.
So equity. So it then becomes a health right. It becomes a basic health right for everyone, which I'm passionate about, because I feel having working both in private and public sector, there are those people who are in dire need, and those are the ones who actually need more these fertility treatments most, because for them, especially in some basic community levels, depending on the society, the role of a woman without a child in the house is really, they're really looked down upon. So this could protect them, could protect the family, could protect them from being disinherited, from abuse and things like that, yet they are not able to afford. They're only able to make the diagnosis, and then they know that they need IVF, and they wonder, what is that? I could not even afford to go and see a provider who can tell me about it. So I'm very passionate about the equity and getting everyone to be able to make a choice. Not everyone will benefit, but they need to be able to make that choice and get the treatment.
Dr. As we close, where do we find you? That's number one. Number two, what would be your message to couples who are watching us right now?
Okay, great. So my office is in 40 Suits, 7th floor, an office called Gynecare. And my message is that if you're confused, okay, that's why there are all these shows and of course the information age and lots of confusion. Seek help. Talk to someone who will guide you to the next level. And if you've been trying for a while and are almost giving up, know that there's a solution for almost everyone. And it's something that we can talk about, that can be talked about by your health provider, and you get direction. And if you're not getting help, because I might not be the best, as in I could give a solution that is not working for you, always seek a second opinion, and I'm sure it exists. And wishing you all the best, and because I'm sure most people watching either know of a couple that is trying to get a baby or are wondering whether they would want to get a baby soon. Wish you all the best in this journey. Dr.
Mashira has, Doctor, we've just scratched the surface. There's a lot more to discuss, and we want to thank you for coming here. This conversation definitely must continue. And as we keep on looking for solutions to those who are trying to be parents out there, all is not lost. Find yourself an OBGYN will guide you through that, and to the government of Kenya as well, as you put things in order to be able to offer what Dr. is saying, to be a healthcare system that is affordable, accessible to all. Perhaps it's a conversation that all the 55 million of us must get onto. To those as well that are trying to get children out there, all the best. Dr. Mashira, who is a gynecologist, asanteni sana. And this is Health and Wellness.